Hey everyone, my name is Anshuli Patel and we're group 20. In my group there's Reshma, Ross, Damaris, and Janelle, and today we're going to be talking about the drug Tarceva, or the name Erlotinib. The objectives for today are going to be what is Erlotinib, what description of the drug class, understand the mechanism of action, pharmacokinetics and the dosage form, adverse effects and drug interactions, describing the primary mechanism of resistance, and patient counseling. So what is erlotinib? Erlotinib is classified as an epidermal growth factor receptor or EGFR inhibitor. So the clinical use for erlotinib can be monotherapy or combination. If it is monotherapy, it will be for the treatment of patients with metastatic non-small cell lung cancer whose tumor have epidermal growth factor receptor on exon 19 deletion or exon 21 substitution mutation. And you're going to give this as a monotherapy after you have after it has been detected by the FDA approved test, receiving first line maintenance for this, and it could be used as a combination with gemcitabine for locally advanced metastatic pancreatic cancer.
So now that we have a better understanding of what this drug is for, we can move on to how it works in the body. The exact mechanism of action of erlotinib is not known, but it does appear to interact with the epidermal growth factor receptor, which is essential to its action. So the first question that we must answer is, what is an EGFR? The epidermal growth factor receptor, or EGFR, is a transmembrane glycoprotein that is present on the cell surface of both normal and cancer cells. When epidermal growth factor binds to this receptor, it causes a dimerization and autophosphorylation of tyrosine. This reaction, in turn, spurs downstream activation of factors that are responsible for the cell growth and its proliferation. Let us now take a closer look at this process. In step 1, some type of signal molecule or ligand, in this case we'll assume epidermal growth factor, is in the area of the inactivated receptor. In step 2, the epidermal growth factor binds to two areas of the inactivated epidermal growth factor receptor. This binding results in a dimerization or a joining of the two inactivated receptors to form one active receptor. In step 3, the now activated receptor causes activation of the tyrosine kinase regions, which in turn phosphorylate themselves. The receptor is now fully activated. The final step, step 4, is these activated or phosphorylated tyrosine regions attract relay proteins, which are inactive, but once they bind to these areas on the receptor, are activated and initiate various cellular responses, including growth, proliferation, angiogenesis, etc. Some tumors that cause non-small cell lung cancer are known as EGFR mutation positive disease. These mutations, which are caused by either an exon 19 deletion or an exon 21 substitution mutation, causes the tumor cells to become highly dependent on the EGFR pathway for growth. Erlotinib takes advantage of this. Erlotinib binds intracellularly to the EGFR in the tyrosine kinase region. By binding in this region, it blocks the autophosphorylation of the tyrosine. This in turn prevents activation of the receptor and in turn blocks the various downstream activities discussed in the previous slide.
Now we have the better understanding of the mechanism of action of erlotinib. Let's look at the pharmacokinetics of the drug. Erlotinib is orally 60% absorbed, and when it's taken with food increases oral bioavailability. Erlotinib is mostly plasma protein bound, specifically albumin and AAG, which is the alpha-1 acid glycoprotein. The plasma half-life of the erlotinib is approximately 36 hours, and it is metabolized primarily through CYP3A4 enzymes. Erlotinib is extensively metabolized as metabolites in feces and urine. Erlotinib comes in only one formulation, which is of film-coated tablets, and it comes in 25 mg, 100 mg, and 150 mg.
What are the most common adverse reactions seen in the patients taking erlotinib? Patients taking erlotinib may experience the following. Number 1, anorexia. And what anorexia is? It is an eating disorder that causes people to obsess about their weight and what they eat, showing abnormally low body weight. They also can experience cough, diarrhea, dyspnea. And what dyspnea is? It is when a person has difficulty breathing. Another side effects are fatigue and rash. And I'm going to emphasize in the rash because it's something that affects these patients very common. The rash will manifest in their face, neck, upper, chest, scalp, and in the back. How we can manage these symptoms and how we can advise our patients. We can tell them, like for example, to drink plenty of fluids, avoid sun exposure, and use SPF protection. They also can use antihistamines and dermatologists recommended lotions. They also should avoid hot showers and baths. They should also limit the shaving frequency and to use mild detergents. It is important to manage the rash before and during the treatment. Once the treatment is completed, the symptoms then will subside. Lastly, they also can experience nausea and vomit, which are one of the most frequent adverse effects for these medications. What about the use of erlotinib in pregnancy and breastfeeding? Erlotinib can cross the placenta, thus causing fetal harm. The information is limited, but these results were observed in animal reproduction studies. In base of this information, it is advised that females use effective contraception during treatment and for at least 1 month after the last dose of erlotinib. And lactating women shouldn't breastfeed while in treatment and for 2 weeks after the final erlotinib dose. What are some drug interactions that we can have while taking erlotinib? Let's start with the food interactions, like for example grapefruit, which it may decrease metabolism and increase erlotinib plasma concentrations. To prevent this to happen, it should be taken on an empty stomach at least 1 hour before or 2 hours after food ingestion. For drug-drug interactions, we can see that erlotinib serum concentration levels could either decrease or increase depending on the concomitant drug that has been used, and we should adjust accordingly. we are going to see a decrease in erlotinib serum concentration when taking it, for example, with the following drugs: antacid, proton pump inhibitors, H2 receptor antagonists, cigarette smoking people, and with the CYP3A4 inducers medications. In the case of antacids, we will separate the administration of erlotinib and any antacid by several hours to minimize the risk of a significant interaction. In the case of the H2 receptor antagonists, if concomitant treatment cannot be avoided, erlotinib should be dosed once daily, 10 hours after, and at least 2 hours before H2 antagonist dosing. In the other hand, when using erlotinib with these following two drugs, like ciprofloxacin and CYP3A4 inhibitors, then we may see an increase in the erlotinib serum concentration. For both medications, when a combination can be avoided, we have to monitor the patient closely for the development of severe adverse reactions. And if such severe reactions occur, we need to reduce the erlotinib dose in 50 milligrams increments. Lastly, when using erlotinib with anticoagulants like warfarin, this may cause an increase in the serum concentration of warfarin. It is for that reason that is very important to monitor the therapy. In conclusion, we should strive for avoiding the concomitant use of these medications with erlotinib if possible.
Okay, so moving on to mechanism of resistance. Erlotinib is part of a class of drugs that are the EGFR TKIs, which is epidermal growth factor receptor tyrosine kinase inhibitors. So these drugs play a huge part in non-small cell lung cancer, but there is actually some resistance that can occur to these medications and cause a huge problem for actually supporting efficacy for these drugs. Drug resistance seems to come from numerous different mutations as one of the biggest reasons behind the resistance. So what it really is it's a different amino acids that are substituted in the wrong place and causing a mutation. So actually half of all the non-small cell lung cancer tumors actually develop a resistance because of the mutation at 790 point on the EGFR from substitution from threonine to methionine. So what happens when this mutation occurs? So erlotinib will bind to the mutation, and it actually allows the tumor to grow faster, and which will lead to larger tumors overall, and in the long run leads to resistance to the medication. So like I said on the last slide, there are a bunch of different mutations that occur, and this is one of the biggest reasons why there is resistance to erlotinib. So a couple of the other biggest mutations that occur are the change from leucine to arginine at the 858 point on the EGFR, and a change from aspartate to tyrosine at the 761. So these are both substitutions that are in the wrong spot. Erlotinib can also have resistance because of a couple of other reasons. So on the EGFR, it can actually bind to mesenchymal to epithelial transition factor, or MET. And so many cancers have shown an association with these two together. So what is MET and how does it work? So MET actually gets activated by HGF, which is hepatocyte growth factor. And when these two are linked together, it can cause a partial resistance to any of the EGFR TKIs by stimulating cell invasion and starting metastasis.